Hi, this is Dr. Akhtar Amin, and today's topic is eyelid malignant lesions. And remember that 80% are benign lesions, and while the remaining 20% of eyelid lesions are malignant, and 5 to 10% are of all skin lesions are uh, eyelid lesions. First of all, characteristics of malignancy. So whenever you come across a lesion, always look for these points. Number one is ulceration, uh, induration. So you can see in this picture there is ulceration, and in second picture you can see this lesion is irregularity, telangiectasia in this picture. This picture you can see pearly appearance, and loss of eyelid margin architecture. So these points, when you come across, these are characteristics of malignancy: ulceration, induration, irregularity, destruction of the eyelid margins, non-tenderness. So the malignant lesions will be non-tender. Telangiectasia, you can see here. Pearly borders, you can see here. Tethering to underlying structures, and madarosis, loss of eyelashes. So before starting, there are some rare predisposing conditions which can lead to malignancy, and if these occur in young patients, so there is a chance of converting to malignant conditions. Number one is xeroderma pigmentosum. So in this picture you can see there are skin damage due to exposure to sunlight, which leads to progressive there is progressive cutaneous abnormalities. 90% have ocular or periocular involvement. 65% experience photophobia. It is inherited and autosomal recessive. The patients will have bird-like facial appearance. You can see there is significant propensity to development of basal cell carcinoma. So basal cell carcinoma is it can convert to basal cell carcinoma. It can also convert to squamous cell carcinoma and also melanoma. And there may be multiple melanomas, and also there may be conjunctival malignancies have also been reported. Another rare condition is Golden-Gold syndrome, also known as nevoid basal cell carcinoma. It is a rare autosomal dominant disorder, and there is extensive congenital deformities of the eye, as well as the face, bone, and central nervous system. So here you can see there is skin changes, there are jaw cysts, elevated scapula, here you can see chest and pectus deformities, enlarged head circumference, syndactyly, feet or hands, pitting of the soles, palms, and spine misalignment. So this is Golden-Gold. Another is rare condition is Muir-Torre syndrome, also autosomal dominant and predisposed to cutaneous and internal malignancies. Like cutaneous include basal cell carcinoma, sebaceous gland carcinoma, and keratocanthoma. while the internal are colorectal and genitourinary carcinomas. These are the most common systemic tumors. Another one is basic syndrome. It can lead to multiple basal cells carcinomas. And others are the immunosuppression, prior retinoblastoma, and albinism. These patients can also lead to eyelid malignant tumors. The first one is basal cell carcinoma. It is the most common human malignancy. Basal cell carcinoma is the most common human malignancy. It typically affects older individuals. The most important risk factor are the fair skin, inability to tan, chronic sun exposure. 90% of cases occur in the head and neck, and 10% involves the eyelid. It is the most common malignant eyelid tumor. 90% consists of 90% of all malignant tumors of the eyelid. And the most common site is lower eyelid, followed by medial canthus, followed by upper eyelid, followed by lateral canthus. And it is slow growing, locally invasive, but non-metastasizing. Keep in mind, it is locally invasive but non-metastasizing. It do not metastasize. Tumors which are near the medial canthus, they invade the orbit and sinus. They are difficult to manage, and there is risk of recurrence. And the recurrent tumors are aggressive. So the most common is lower lid. This you can see again at the lower lid, and here it is near the medial canthus. It is more aggressive. Here you can see there is rolled edges within umbilicated center, and in the picture you can see there is central ulcer. Here you can see rolled pearly borders with telangiectatic vessels and lash loss, also known as medarosis. So the histopathology, this tumor arises from the cells that form the basal layers of the epidermis. So they arise from the basal layers of the epidermis. That's why it's called basal cell carcinoma. Then these cells proliferate downward, and there is palisading at the periphery of a tumor. There are different clinical appearance. Number one is nodular. Nodular is shiny, firm, pearly nodule, and there is small overlying dilated blood vessel. Here you can see, and the growth is slow, and it takes 1 to 2 years to reach 0.5 centimeter. So it is shiny, there is pearly, and there is blood vessel, and it is firm. Another one is nodular ulcerative, also known as rodent ulcer. There is central ulcer, and there is pearly raised rolled edges. There is dilated irregular blood vessels, telangiectasia, at the lateral margins. and then they erode a large portion of the eyelid with time. And there is sclerosing, also known as morpic. This is less common and difficult to diagnose. Why? Because it infiltrates laterally beneath the epidermis. Beneath the epidermis is an indurated plaque. You can see induration of the plaque. And margins of the tumor may be impossible to delineate clinically. And the lesion tends to be much more extensive on palpation than inspection. So you cannot find it on inspection, but it can be found more on palpation. So on cursory examination, a sclerosing BCC may simulate a localized area of chronic blepharitis. This is sclerosing. So other types are not usually found on the eyelids. These are so important thing is sclerosing BCC can mimic a localized area of unilateral chronic blepharitis. Now a second type is squamous cell carcinoma of the eyelid. It is much less common, but it is more aggressive tumor than BCC because it metastasizes to the regional lymph nodes in 20% of cases, and there are dysplastic changes throughout the thickness of the epidermis. So careful surveillance of the lymph nodes, regional lymph nodes, is very important aspect of initial management. There is perineural spread to the intracranial cavity via the orbit. Perineural spread, and there is 5 to 10% of eyelid malignancies which are squamous cell. So they constitute 5 to 10%. And they may arise de novo. They may arise from the pre-existing actinic keratosis or from the carcinoma in situ, also known as Bowen disease, intraepithelial carcinoma. In patients who are immunocompromised, such as there is AIDS or renal transplantation, these patients are increased risk. And so those with a predisposing syndrome such as xeroderma pigmentosum, and the tumor has a predilection for the lower eyelid and the lid margin, commonly occur in older individuals with a fair complexion. Older individual with a fair complexion, and there is history of chronic sun exposure. The diagnosis is sometimes difficult because of the certain ostensibly benign lesions such as keratokeratoderma and cutaneous horn, and they reveal histological evidence of invasive SCC at deeper levels of the section. So histopathology, this tumor arises from the squamous cell layer of the epidermis. Squamous cell layer. There are varying sized group of atypical epithelial cells, and there is prominent nuclei. There are prominent nuclei and abundant eosinophilic cytoplasm. There are keratin pearls. there are intercellular bridges known as desmosomes. Clinical features. There are clinical types. There are no pathognomonic characteristics. So the tumor is indistinguishable from a BCC. But surface vascularization is usually absent. The growth is more rapid. Hyperkeratosis is more common. Hyperkeratosis, rapid growth, surface vascularization is absent. This is a nodular type, hyperkeratotic nodule. There is crusting, erosions, fissures. Ulcerative, red base, sharp and defined, indurated and everted borders. Pearly margins, telangiectasia are not usually present. Cutaneous horn, and there is underlying invasive squamous cell carcinoma. So this was all about the squamous cell carcinoma. So the keratocanthoma and cutaneous horn may reveal histological evidence of SCC and deeper levels of sectioning. So this keep in mind about squamous cell carcinoma. Another tumor is keratocanthoma. Keratocanthoma is rare and it is rapidly growing but subsequently regressing tumor. Usually occurs in fair-skinned individuals with a history of chronic sun exposure. Immunosuppressive therapy is also a predisposing factor. Invasion and metastasis are rare. Histopathological examination reveals there is irregular thickened epidermis surrounded by a acanthotic squamous epithelium. There is a sharp transition from the thick involved area to the normal adjacent epidermis. This is referred as shoulder formation, and a keratin filled crater may be seen. How will you diagnose? There is a pink and dome shape, you can see pink and dome shape hyperkeratotic lesion, often on the lower lid. It may double or treble in size within weeks. You can see growth then ceases for 2 to 3 months, after which spontaneous involution occurs with a keratin filled crater may develop. Here you can see complete involution may take up a year and usually leaves unsightly scar. The treatment is complete surgical excision with a margin of at least 3 mm or utilizing Mohs surgery. Radiotherapy, cryotherapy, local chemotherapy are sometimes used. So this is keratocanthoma. Another one is sebaceous gland carcinoma. It is very rare and it is slow growing tumor. It most frequently affects the elderly with a predisposition for females, elderly and females. It usually arises from the meibomian glands. Although on occasion it may arise from the glands of Zeiss or elsewhere. Histopathology demonstrates lobules of cells with pale, foamy, vacuolated, lipid-containing cytoplasm, large chromatic nuclei. Overall mortality is 5 to 10%. Mortality. And the adverse prognostic features include upper lid involvement, tumor size of 10 mm or more, and duration of symptoms for more than 6 months. So here you can see large hyperchromatic nuclei. Clinical features. In contrast to basal cell carcinoma and squamous cell carcinoma, the sebaceous gland carcinoma occurs more commonly on the upper eyelid. Here you can see on the upper eyelid, where meibomian glands are more numerous. So this is important. There may be simultaneous involvement of the lower lid and upper lid on the one side in 5% of patients. Yellowish material within the tumor is highly suggestive of sebaceous gland carcinoma. Yellowish material. And there are two types, nodular and spreading. In nodular there is discrete hard nodule, most commonly in the upper tarsal plate. There is yellow discoloration due to presence of lipid. It can be mistaken for lesion. While in the spreading type, there is infiltration into the dermis. There is diffuse thickening, the lid margin, eyelid distortion, and eyelid loss of eyelashes. It can be mistaken for blepharitis, and here lesion. So the important point is that sebaceous gland carcinoma can be confused with chronic or recurrent localized meibomian gland inflammation. Another tumor is lentigo maligna and melanoma. So they rarely develops on the eyelids, but they are lethal. And pigmentation is a hallmark of skin melanomas. Pigmentation. Half of lid melanomas are non-pigmented. So keep in mind, half of melanomas are non-pigmented. So they may give rise to diagnostic difficulty. So what are the features which are suggestive of melanoma? They include recent onset of pigmented lesion, and along with this, change in existing pigmented lesion, irregular margins, asymmetric shape, color change, presence of multiple colors, diameter greater than 6 mm. These are the features suggestive of melanomas. What is lentigo maligna? Melanoma in situ, also known as melanoma in situ, intraepidermal melanoma, Hutchinson freckle. Uncommon condition there is in sun damaged skin in elderly individuals. Malignant changes may occur, infiltration of the dermis. So there is proliferating within the basal layers, and clinically there is pigmented macule, irregular borders. Treatment is usually by excision. Nodular thickening, areas of irregular pigmentation are highly suggestive of malignant transformation. Nodular thickening in areas of irregular pigmentation. So this is lentigo maligna. Now melanoma, there are large atypical melanocytes invading the dermis. There is superficial spreading melanoma. There is a plaque. In superficial spreading melanoma, there is a plaque. Irregular outline, variable pigmentation. Another is nodular melanoma. There is a blue-black nodule and surrounded by normal skin. Treatment is usually by wide excision. Include local lymph node removal. Early detection carries a good prognosis, and surgical excision is often curative. Long-term survival is poor in patient with metastasis. Radiotherapy, chemotherapy are limited efficacy. New approaches using immunotherapy show considerable promise. Merkel cell carcinoma. Merkel cells are a form of sensory receptor concerned with light in touch. Merkel cell carcinoma that is rapidly growing. Highly malignant tumor. Typically affect the older adults, and its rarity may lead to difficulty in diagnosis and delay in treatment, and 50% of patients have metastatic spread by presentation. And there is a violaceous, well demarcated nodule. Here you can see violaceous, well demarcated nodule with intact overlying skin, most frequently involving the upper eyelid. And there are sheets of Merkel cells. Treatment is by excision, often with adjuvant therapy. Kaposi sarcoma, it is a vascular tumor. This is a Kaposi sarcoma. You can see it is a vascular tumor. Typically affects individual with AIDS. So AIDS is important. Many patients have advanced systemic disease, and the tumor may be only clinical manifestation of HIV infection. So there are proliferating spindles, vascular channels, inflammatory cells. Clinically it is pink, red, violet, brown lesion. It may be mistaken for hematoma or nevus. Treatment is radiotherapy, excision, and optimal control of AIDS. Thank you very much.